my pleasure to bring back Dr. Robert Wright, who will introduce the speakers and moderate the next section. Dr. Wright.
Thank you, Terry. It's my privilege to introduce the next three speakers, and for this session, which is called the Climate Health Research Roundup. Two of the scientists are members of the Institute for Exposomic Research. The third trained here at Mount Sinai, recently took a position at Yale. Dr. Bian Liu is an associate professor here at Mount Sinai in population health. She applies statistical machine learning methods to better understand how the environment affects health outcomes. Dr. Maayan Yitshak-Sade is an assistant professor in the environmental medicine and public health department. Her research is applying regression and causal modeling methods to investigate the links between multiple environmental exposures and risk factors for cardiovascular disease. And our third speaker is Dr. Daniel Carrión. He recently finished his postdoctoral fellowship with us in environmental medicine at Mount Sinai and has started a position, I believe, as of January 1st at Yale University as an assistant professor of environmental health sciences. He's also the director of education for the Yale Center on Climate Change and Health. And I believe Dr. Yitshak-Sade is actually our first speaker. So welcome, Maayan.
Hello, everyone. Thank you, Dr. Wright, for this introduction. I hope you can see my slides okay.
Yes.
Great. So today, Dr. Carrión, Dr. Liu, and myself will discuss some of the latest climate change-related research we do here at Mount Sinai. As you've already heard this morning, climate change has many devastating consequences. And our talk today will be focused specifically on worse air quality, rising temperatures and increased frequency of heat waves, and exposure to extreme weather events. We'll talk about the interactions between climate variables and air pollution, the importance of investigating both moderate exposures and extreme weather events, and the role of environmental health disparities. And finally, we'll end with a few closing takeaways that are relevant for clinicians. The first question that I wanted to answer today is the relevance of climate change to patient care. Climate exposures can cause or worsen many diseases: cardiovascular, respiratory, allergies, metabolic diseases, and more. Not only that, extreme weather events, power outages, and wildfires, which are more frequent with these changing climate, can limit access to healthcare and therefore have an effect on patient care as well. The second question that I wanted to answer is, why do we talk about air pollution at a climate change conference? Air pollutants and climate change drivers originate from common sources. Therefore, by reducing emissions from fossil fuel burning, we will improve both air quality and climate at the same time. In addition, air quality is highly correlated with weather. For example, in hotter days, ozone levels are higher. In wildfire events, exposure to fine particulate matter is significantly higher. And also, we often find synergistic effects between air pollution and temperature. And I will discuss it in more details later on. In my group, the research is mostly focused on the effects of air pollution, particulate mass and its components, and different climate variables, and their effect on cardiovascular disease, and also how these effects can be mediated through worsening or promoting metabolic diseases. Just to show a recent study as an example, this is a study conducted by Dr. Mike He, my postdoc. He studied the effects of temperature and air pollution exposure on hemoglobin A1C, measured among women enrolled in the PROGRESS cohort. It's a cohort in Mexico City area. And he found that air pollution, 3 months average of air pollution exposure was associated with significantly higher hemoglobin A1C levels. And on the other hand, hotter temperatures were associated with lower hemoglobin A1C levels. And these are blood measurements taken 4, 6, and 8 years after delivery. Although these main effects are very important, it is also important to study the potential interaction between these exposures and how they affect certain health outcomes jointly. Rising temperatures and increased temperature variability are some of the most important consequences of climate change. Unstable temperatures can modify the person's response to temperature. You know that if people are exposed to temperatures that are not used to, it can affect the way they cope with temperature. It can affect their heart rate, blood pressure, blood viscosity, and autonomic nervous system. Also, we know that temperature can modify the response to air pollution. Physiological heat stress can increase susceptibility to air pollution effects. And also, there are often different particulate matter compositions in warmer days and colder days. So in many studies, we find that on hotter days, air pollution exposure is associated with larger health effects. And this is shown in this study where we studied the combined effect of temperature and air pollution on cause-specific hospital admissions among Medicare enrollees in New England. And we found that particulate matter air pollution exposure was associated with respiratory and cardiovascular hospital admissions. And these effects were significantly larger in months where weather was less stable, meaning that climate instability contributes to population vulnerability to air pollution effects on the respiratory and cardiovascular system. It is important to note that even air pollution exposures below the current national ambient air quality standards are associated with adverse health outcomes. As you've already heard today, the Clean Air Act requires the EPA to set a set of guidelines with air pollution standards that mitigate health consequences and environmental consequences of air pollution exposure. For fine particulate matter or PM2.5, for example, the annual standard is 12 micrograms per cubic meter. And in 2020, a review committee of the EPA that reviewed these standards decided that based on the available evidence, the current primary PM2.5 standard are requisite to protect public health with an adequate margin of safety from the effects of PM2.5 in ambient air and should be retained without revision. Unlike the EPA, the WHO, the World Health Organization, last year released a new set of global air quality guidelines, and they concluded that harmful air pollution effects on health are observed at levels that are much lower than previously thought. They recommended to markedly reduce the air pollution standards. For example, for PM2.5, they recommended to reduce the standard from 10 to 5 micrograms per cubic meter. And just as a reminder, in the US, the standard today is 12. And the basis of this decision is evidence from different studies that show the consequences of air pollution exposure persist in exposure to these lower or moderate air pollution levels. And this shows why it is important to study the effects of moderate air pollution exposure. First, in higher air pollution levels, measurement error is more frequent because these higher levels are more rare, and therefore these studies are more prone to bias. Second, it is important to conduct studies that study the effect of moderate air pollution exposures to understand if current thresholds are sufficient to protect health and the environment. And finally, we know that the sources and composition of air particles may differ between low pollution days and high pollution days. So it is important to focus on these moderate exposures in addition to exposure extremes. And this is a recent study that we conducted, and it was not peer-reviewed yet. And we assessed the association between air pollution exposure and first documented diabetes occurrence in a national cohort of Medicare enrollees. So we included about 264 million person-years of follow-up of people who were enrolled in Medicare programs between 2000 and 2016, and these are older adults, 65 years and older. And in this study, we assessed the effect of fine particulate matter, nitrogen dioxide, and ozone on diabetes risk. And we specifically focused on zip codes in which air pollution exposure did not exceed the current national ambient air quality standards for the entire study period. So hypothetically, if these standards were enough, we shouldn't have seen any adverse health effects associated with air pollution in these zip codes. However, we did find increased risk for diabetes associated with PM 2.5, with NO2, and with ozone. And not only that, for PM 2.5 and ozone, the effects were larger compared to the entire population that was exposed to the entire range of the pollutants. And we see the same results repeatedly in other studies as well. This is just another example where we studied the effect of fine particulate matter on mortality from cardiovascular disease. And we found that higher PM 2.5 exposure was associated with 2.3% increase in the risk to die of cardiovascular disease. And results were very similar when we restricted the population only to those who never experienced air pollution levels higher than the current standards within the study period. It is also important to see that in this specific study, air pollution effects on cardiovascular mortality were significantly larger in neighborhoods with higher percent of Black residents and higher Black to white resident ratio, and we will hear more about environmental health disparities in this presentation. So to recap my part of the presentation, air pollution and climate change are strongly related. In fact, air pollution effects on health are often shaped by weather parameters. The current EPA's national ambient air quality standards are not sufficient to protect human health from air pollution exposure. And as I said, we often find larger air pollution effects in neighborhoods with higher proportions of racial minority populations, which shows the importance of addressing environmental health inequities. Thank you.
Hi, everyone. My name is Bian Liu. My talk will focus on the impact of disaster events, particularly hurricanes. I was going to say my portion of the talk is about the health impact under non-normal conditions in contrast to the normal conditions, such as day-to-day exposure to air pollution and temperature that Maayan has talked about in her presentation. But that statement may not be entirely accurate. As Dr. Shepard mentioned in his talk earlier, we are entering into a new norm, which is a world with more frequent disaster events. As you will see from you can see from the climbing lines shown in this slide, the frequency of $1 billion cost disaster events has been increasing over time. Each colored line on this figure represents a different year. The black line indicates the average between 1980 and 2021. There are some variations from year to year, but on average, we are at a level of 7 events per year. I will specifically talk about 2 events. For Hurricane Sandy in 2012, I will talk about its mental health impact based on individual participant level data. And for Hurricane Harvey in 2017, I will look at its impact at the neighborhood level. Then I will circle back to Hurricane Sandy and the tropical cyclones in general and talk about their impact on healthcare utilization. For Hurricane Sandy, I worked on 3 projects. Each of these projects has a different emphasis and design. For example, Project Light was to understand the overall impact of mental health across Long Island, as well as part of the Queens and Staten Island of New York City. Project Restoration focused mainly in Rockaways, which is one of the hardest hit areas with a diverse population. And the objective of this project was to screen and link individuals with care to improve their mental health. We also collected some longitudinal data in a follow-up study of the original participants from both Project Light and Project Restoration. These three projects also share many commonalities. As you will see in the next slide, in a nutshell, all three studies are based on survey data from a comprehensive, a convenience sample of the people living in around New York City area. We asked the participants about their exposure and experience during Hurricane Sandy using modified validated questionnaires on exposure and mental health difficulties such as anxiety, depression, and PTSD. We summarized the 30 hurricane exposure items into 3 types of exposure: personal damage, property damage, and both. We then examined the association between hurricane exposure and mental health outcomes, adjusting for potential confounders. The results I highlighted in the next slide indicate that, as you will see in the highlighted the red box, in both of the study on the Rockaways and the follow-up study, there was a consistently higher odds of the PTSD associated with the increasing hurricane exposure. The odds are significant no matter what type of exposure score we use. In addition, in Rockaways, increased property damage related to hurricane exposure score was also associated with higher odds of anxiety and depression. These analyses demonstrated that the adverse impact of disaster event exposure on mental health at the individual level during Hurricane Sandy. Now for Hurricane Harvey, my focus is going to be at the neighborhood level. Next slide, please. And next slide, please. So here, I show a side-by-side comparison of families affected by Hurricane Harvey at the census tract level on the left and median household income on the right. Even without doing any formal analysis, we can intuitively discover that many tracts that were heavily affected by the hurricane, shown as darker red color on the left panel, especially in the highlighted yellow circle, are also low-income areas as shown as the light red to no color on the right panel. Now, income is just one measure of the vulnerability of a community to natural disasters. CDC has come up with a composite measure called the Social Vulnerability Index, SVI, to capture the health of a neighborhood to withstand disaster events. This overall SVI is composed of 15 individual measures and can also be decomposed into 4 domains. We can then use the vulnerable index to correlate with the hurricane damage in a model called the geographically weighted regression to identify vulnerable areas. The red areas shown in the next slide here indicates a positive correlation between SVI and hurricane damage. The darker the red color, the stronger the positive association. So tracts with the darker red are the neighborhoods that need more help. We also studied a different map in a separate investigation about Hurricane Harvey. Here in this map, we mapped out facilities that reported incidents during the hurricane. The different colored dots in the figure indicate a different type of facilities. Depending on the facility type, the incidents reported could be oil spills or chemical release, for example. The background color in the figure indicates the level of the socioeconomic status of the census tracts. The darker the gray, the better off the area. We then modeled the association between SES quintiles and the occurrence of facility incidents, adjusting for factors such as the extent of flooding. We found that neighborhoods with the highest SES quintile had a significantly lower odds of incidents compared to neighborhoods at the bottom SES quintile. The results suggest that potentially facilities in the low SES areas may be less well maintained, thus they have incidents during a storm or event. And people living in these areas may have additional environmental pollution exposure during the hurricane. Now I'm going to circle back to Hurricane Sandy and the hurricanes in general with a focus on healthcare utilization. We found an uptick of ED visits in the 2 days following the landfall of Hurricane Sandy in New York City area. And the increase was mostly driven by respiratory diseases. Our study focused on ED visits in 2 counties in New York, Nassau and Suffolk. Another study looked at a larger area, which included 8 counties in New York State. They found increased ED visit related to pregnancy complications associated with power outage resulted from Hurricane Sandy. In another study that used a large national data set over a 16-year time span, the authors found that significant excess hospitalizations associated with exposure to tropical cyclones among older adults in the US. From a single hurricane to tropical cyclones over 16 years, I hope you got a sense about how these events could affect adversely on our physical and mental health, our community's health, and how they could stress our infrastructure, such as chemical facilities and healthcare systems. With the continued increased frequency of costly disaster events, my take-home message would be we really need to strengthen our resilience to these events at personal and community level. Thank you. Now I'm going to pass the baton to Daniel.
Thanks so much, Dr. Liu. So I'm excited to speak to you all about this piece. My colleagues discussed issues of vulnerability and disproportionate exposures, but now I'll speak a little bit more directly to how I think about climate and environmental exposures within the context of disparities, inequality, and justice. First, I'll present this schematic that connects exposures that cause a given disease and those diseases that may lead to a severe outcome like death. And a simplistic representation about how social inequality is related to that is that social inequality could lead to differences in the distribution of exposures, or otherwise meaning that certain groups are more exposed than others. Social inequality may also independently lead to differences in baseline levels of disease, and it may also independently lead to differences in the likelihood of a severe outcome. This is, of course, a generalization, but helps me think about how I need to tackle a particular research question. Of course, social inequality is an umbrella term for many different social processes, such as racism, sexism, heterosexism, and so on. In this case, I'm going to discuss a particular manifestation of structural racism, which is residential segregation. Residential segregation is a particularly important issue because it represents the co-location of many different determinants of health, from housing to food access to healthcare access to healthcare quality, all the way to those that are more proximally related to environmental exposures, like land use and land cover, which just essentially means the types of things that we use land for, like parks or residential space or commercial space, and relatedly, the ambient temperature of those areas. So this particular paper looked at the relationship between historical redlining and present day land cover. You likely know that redlining is a nickname for the historical racist housing practices of the 30s and 40s, whereby communities were designated as good or bad investments based largely on the racial composition of that area. Good investments were those termed grade A, and bad ones were those termed grade D. So what this figure is showing us is that areas designated as D or redlined in the 30s now have the lowest NDVI, which is a satellite measure for how green an area is. And using causal inference methods, the authors of this study then found that compared to the nearest comparator, so in this case, comparing D to C, C to B, and then B to A, that these racist housing practices are indeed consistently associated with lower greenness today. And relatedly, others have found that these historical housing practices are now associated with higher land surface temperatures, which is a satellite measure of how hot the surface temperature is. So all B, C, and D communities or redlined communities are all hotter today than those green-lined communities back in the 30s and 40s. So this work is all extremely important, but has some limitations. First is that residential segregation is not a thing of the past, but still very much persists and has changed because there's been more developed land area since the 30s and 40s, groups have moved around, so on and so forth. Also is that land surface temperature, which I mentioned earlier, is related to air temperature, but it's not exactly the same. And air temperature is important from a health perspective because it's more closely related to human thermoregulatory capacity. So one of the things that I worked on while I was at Mount Sinai was exposure science. So exposure science is loosely how to create accurate and unbiased estimates of what humans have been historically exposed to on a day-to-day basis. In this case, air temperature. So when we create some sort of exposure model or metric, we oftentimes will check how it did compared to an established one. In this case, we compared against a model developed by NASA and NOAA called the NL-2 model, which is used by the CDC in its heat and health tracking system. We created our own temperature model using machine learning methods named the XGBoost model, named after the algorithm that we used to make the predictions. And aside from using very different methods to approximate historical air temperature, one of the biggest differences between these two approaches is depicted by the map on the right here. So this map is of the New York City area at midnight of July 11th, 2011, during a heat wave. And the predictions from our model are represented by the small boxes colored from blue to red. And the large overlaid rectangles are the size of the NL-2 estimates. And those are approximately 11 by 14 kilometers. So if you look at the rectangle in the very middle, you'd see that it covers most of Manhattan, part of New Jersey, part of the Bronx, and even part of Queens, meaning that the NL-2 estimates would give you one number for that entire area. Whereas ours reconstructs much more of the differences you would feel within and between neighborhoods if you were to go for a run or a jog during that heat wave. So these finer estimates probably explain why our model does better at predicting the temperatures at known ground observations like weather stations. But these finer predictions also have ramifications for assessing exposure disparities. So this is in this unpublished work for our study area, the 13 states of the Northeast, from Maine to Virginia, we show that the NL-2 estimates and the XGBoost predictions both tell you that present day segregation is associated with hotter average summers for Black people. But the magnitude of that disparity is different based on the model that you use. So using the XGBoost model, you'll see that communities with a higher concentration of Black people and lower concentration of white people experience 53 cooling degree days in 2003 within the same county. See, cooling degree days are a measure of the intensity of a summer, and the NLDAS2 model only shows an additional 20 cooling degree days in more segregated areas. And if you were to look across all of the years, you would see that this trend is consistent with varying differences over time. So there's a lot of room to achieve justice and improve the situation for minoritized groups. Targeted place-based interventions are important, including things like neighborhood greening, white roofs that reflect incoming solar radiation, improving quality for poor communities, and expanding access to the low-income home energy assistance program. So this program is historically, or LIHEAP for short, is a program that has been historically used to help people with their wintertime heating bills. But governments have the ability to expand this program to help people with their summertime cooling bills, which we know is of increasing importance with climate change. And this is actually something that environmental justice advocates at WEACT and colleagues at Columbia are calling for, and an important opportunity to intervene for health. And this is just a reference to the op-ed that was written by those folks calling for the expansion of the LIHEAP program. So this is an example that I just went over in this particular case, where people who are racialized as Black are concentrated into neighborhoods that are hotter on average, which undoubtedly has numerous downstream health impacts. And I proposed some potential solutions. But this is also an example where the type of tools that we use are also really important to the types of answers we get for our research. And so this is only one example of how one particular situation of social inequality leads to differences in exposure, but there are many other exposures and forms of social inequality, not to mention the downstream epidemiology of how these then precipitate into health impacts. And so as some closing takeaways from all three of our presentations, we hope that you will take away that climate change is really relevant to patient care. It is causing and worsening disease for folks. It also represents, in the case of extreme weather events, limited access to healthcare during these time spans. It's important to consider where patients live, because where they live is strongly associated with the exposures that they're exposed to, and also closely associated with the forms of vulnerability that they experience. We think that more studies need to think about environmental exposures and environmental assessment in terms of patient care, and how this can be leveraged to think about interventions that prevent morbidity and death. And I think, we also hope that folks take away that it's not only these extreme exposures that matter for people's health, but also even moderate exposures that also have health outcomes and adversely affect people's health. And finally, that social inequality is an important upstream factor that we need to consider in all of these types of studies, because they're so closely related, and the ethical implications of that as well. So of course, all of this research takes a lot of support, both financially and with our collaborators. So thank you very much to them.